So Learning from Deafs is a national health programme or policy which was launched in 2017-18, and I'm going to present to you some of my research and relate it to the Learning from Deafs work at Nottingham University Hospitals. And specifically, I'm going to present a document analysis of all the national, the NHS Learning from Deafs reports from 2017 to 2019. So this is a programme of research that's undertaken which basically evaluates the effectiveness of the Learning from Deafs programme. And like lots of health policy, many people may not have even heard of this programme. So in this research, I'm really looking at, do individual clinicians and organisations learn from deafs in healthcare? What does learning and organisational learning mean in the context of patient safety? And does the programme theory, so does the programme, what it's supposed to do, match frontline experience of clinicians and the public? And first of all, I'm just going to give you some context and background to the Learning from Deafs programme before getting into the findings. So this is really a question for you. So how many preventable or potentially preventable deaths are there in hospitals in England every year? And I mean, that in itself brings up a lot of questions, like what is preventable or potentially preventable? And that's very subjective judgment, which is a lot of a problem people had with the Learning from Deafs programme. So just to help give you some idea, there's been quite a lot of studies over the last 10 or so years looking at this, the most famous of which in the UK was a study by Helen Hogan in 2012, where she did a retrospective case record review of adults who died in 10 different acute hospitals in England, and they judged that 5.2% of all deaths had a 50% or greater chance of being preventable. And then similar studies since then have shown a similar sort of amount of potentially, probably or definitely preventable deaths, 3.4 to 6%. And then more recently, there was a study in the northeast of England that judged 0.5% of deaths to have a greater than 50% probability of death being preventable. And in the same year in America, there was a study which judged 8.4% of deaths to be possibly preventable. So in England, between April 2017 and March 2018, there were 299,000 deaths in hospital, or within 30 days of discharge. So these are very rough calculations, and they're not at all meant to be accurate. It's just a rough guide. But if there were 0.5% of those deaths were preventable, that's 1,495 deaths. And if the highest figure from the American study, if 8.4% of deaths were preventable or potentially preventable, that's 25,000 plus deaths. So how did the Learning from Deafs programme come to be? Well, it all started really with the death of Conor Sparrowhawk on the 4th of July in 2013. He was an 18-year-old man. He died in a bath at a facility run by Southern Health. And his mother, Sarah Ryan, was a very fierce woman who was strongly adamant that she wanted to find out why he was not supervised when he died. And that really led to an investigation into the death of Conor. And following that, Sarah Ryan said that she felt there must be other deaths like this at Southern Health and wanted a wider investigation. And that sparked Mazar's independent review, which happened in 2015-16. And basically, Mazar's review demonstrated there was a lack of systematic approach and meaningful change in response to unexpected deaths at Southern Health. And at the time, Jeremy Hunt was the Secretary of State. And as a result of this review, he wrote a letter to the CQC saying that, is this going on at other hospitals, and there needs to be a wider review. So then the CQC did a review looking at the ways that trusts review and investigate deaths of patients in England, and that was published in this report, Learning, Candour and Accountability, in 2016. And that found that there were inconsistencies in the way that the NHS Trust became aware of, investigated and shared learning from deaths. And it really became the hobby horse of Jeremy Hunt. The learning from deaths and patient safety became his real thing, and he really pushed for this programme to be taken forward. And as a result of that, the National Quality Board, which is an organisation made up of the medical directors and the nursing directors from the senior arm's length bodies, so NHS England, NHS Improvement, Health Education England, CQC, Public Health England and NICE, all came together and published this guidance on learning from deaths. And that gave a lot of information and guidance about how trusts should identify, report, investigate and learn from deaths. And as part of that, they made it a legal requirement for all NHS secondary care trusts in England to publish a learning from deaths report within the trust quality account every year. And for those of you who don't know, because I didn't before I did this, or before I worked at NHS Improvement, the quality count is a report about the quality of services offered by an NHS healthcare provider, and they have to be submitted annually onto their trust website by the 30th of June in order for the Secretary of State to review it, or his team. So this is where you can find Nottingham University Hospital's quality accounts under About Us and then in trust reports. I would recommend, if you have time, but I know most people don't, just to have a look at it. It's really interesting, the information you can get about your own hospital. So my study I'm going to present to you is a qualitative and quantitative analysis of the learning from death reports. I'm going to present the data from 2017-18 and 2018-19. I've started looking at the data from 2019-20, but a lot of the reports were late because of COVID, so some of the data is incomplete, so I'm not going to present that. But I've also looked at the data from the Nottingham University hospital reports for the same years, and I'll talk about that within this presentation. So what was required to be published? So the things that were legally required in the quality accounts to be published was the number of patients who have died in the trust in that year, the financial year, the number of deaths included, which were the provider has subjected to a case record review or an investigation, and then the number of deaths which were more likely than not to have been due to problems in care, with an explanation of how you assess this, what the provider has learned from case record reviews, investigations, and what they have done, so what actions they've taken as a result of that learning, and then how they've assessed the impact of the actions described during the reporting period. So there were 6 really key things that they were required to report that have to be reported in the quality account as part of the learning from deaths report. And I also, because these was formed part of the guidance but weren't legal requirements, thought it important to assess whether trusts had had any family or carer engagement, and also if there was any evidence in the reports of sharing the learning from deaths incidents within the trust and more widely. But it is very important to point out at this point that it wasn't a legal requirement to report this, so trusts may have been doing these things but just haven't put it in their report. So as you would imagine with all NHS data, there wasn't very strict guidance about how this information had to be presented. So as a result, looking through these reports, there were 222 learning from death reports in 2017-18. Everyone's done it differently and put all different sorts of information in. This is the quality account and learning from death report from 2017-18. Obviously, I wouldn't expect you to be able to read any of that, but it's just to show the layout, how it varies between trusts, but also between years. So this is 2017-18. This is 2018-19, so the report is getting longer. And in 2019-20, it gets even longer. It goes on to 6 pages. And then this year's report, not many trusts have got theirs out actually, but this is the report from 2020-21, and it's gone shorter again. And I have to say that, and not just because I'm presenting this, but Nottingham University Hospitals is one of the better, definitely, learning from death reports. And I actually emailed the patient safety team when I first started doing them to say how good their report was in comparison to others and how detailed it is and how much more information you can get out of it. So the quality of reporting. So only 44% of all trusts reported all 6 statutory elements in 2017-18, and this did increase in 2018-19 to 50%. And Nottingham University Hospitals reported 5 elements of the statutory requirements in 2017-18 and 6 elements in 2018-19. 2 trusts didn't report any parts of the legal requirements, and in 2018-19, 3 trusts didn't report any part. The total number of deaths reported by a single trust is hugely variable. So in 2017-18, 1 trust reported 3 deaths and 1 community trust reported 7,756 deaths. And there's similar figures, as you can see, for 2018-19. And Nottingham University Hospitals, which is as you know, a big acute trust, reported 3,603 deaths in 2017-18 and 3,424 deaths in 2018-19. The number of case record reviews, again, hugely variable, and obviously this is partly related to how many patients you have that die. If you have 3 deaths, it's easy to investigate 100% of the deaths, and if you have over 7,000 deaths, it takes a lot of work time to investigate all those deaths. So in 2017-18, there were between 0.2% and 100% of deaths were either reviewed or investigated. And in 2018-19, between 0.85% and 100% of deaths were investigated or reviewed by trusts. And in Nottingham, in 2017-18, 1.6% of deaths were reviewed or investigated, and this increased to 7.59% in 2018-19. And your numbers are quite low, relatively, the number of investigations. And I think partly this is related to what some trusts consider to be a review is highly variable, and it's difficult to pick out who is doing a more thorough review or investigation, and so it's quite difficult to compare, really. The other thing that I looked at is, so within the Learning from Deaths guidance, it was suggested that trusts use this structured judgment review to review all case notes, and this was something that was a programme that's put together by the Royal College of Physicians, and training was rolled out, and I suspect some of you have undertaken this training yourselves. So in 2017-18, 50% of trusts said they were using structured judgment reviews, and this increased, as you would expect, to 61%. And Nottingham University Hospitals were using structured judgment reviews from 2017-18 onwards. Now, this is the bit I guess some people think is more interesting, and which caused a lot of controversy when it was published, saying we had the number of deaths judged more likely than not due to problems in care. So in 2017-18, between 0 and 13% of deaths judged due to problems in care were cited by trusts, and this was between 0 and 8% in 2018-19. And in 2017-18, Nottingham University Hospitals reported 2 deaths more likely than not due to problems in care, and in 2018-19 reported 3 deaths more likely than not due to problems in care, so it's quite low numbers. 22 trusts didn't report any figure in this section, so they didn't report 0, they just didn't report anything. And but they did often give reasons for not reporting to justify it, and they said things like, we do not carry out investigations with a view to determining whether the death was wholly or partly due to problems in the care provided. There's currently no research base for this for mental health services, and no consistent accepted basis for calculating the data. And then one trust said that they had agreed with other trusts that they weren't going to report, basically, because they didn't agree with the principle of it. So most trusts did report that they'd learned lessons, even the ones that didn't report deaths due to problems in care. So only 11% of trusts in both 2018-19 and 2018-19 didn't report any lessons learned. And most trusts did report that they'd taken actions as a result of the learning, and this increased the number of trusts that managed to report actions increased between 2017-18 and 2018-19. And Nottingham University Hospitals reported lessons and actions for both years. So I guess the thing that's, for me, as a healthcare professional, is the most interesting thing is like what things came out of this? What did we learn were the problems in care? So the most common things you can see in this table, and none of it is unexpected. These are all things, as I'll come on to, that have come up before. So poor communication was the most common thing, followed by problems in recognition and escalation of deteriorating patients, problems in end-of-life planning or treatment escalation planning, and then problems with documentation, including consent, lack of clinical knowledge, consideration, differential diagnosis or seeking advice, and then a lack of or problem with risk assessments, interventions. And the last one, that's more common, seems to be more common in mental health trusts than in acute trusts, but some trusts did find that a problem as well, sort of problems with risk assessments for VTE, for example. And as you can see, Nottingham, following lots of the other trusts in the country, cited some of these themes. And this, you don't really, if you wanted to look up what the individual things are, you can see in the paper that we've published about this to look them up. But as you can see, things don't really change much between the years, and the learning stays pretty much the same. The only ones that are really significantly different is towards the end of the table in AP. That's that shows an increased problem in engagement with families, or that people have noticed that anyway. And in C, that was problems relating to patients with learning disabilities. So I've combined the learning from both the 2017-18 and 2018-19 Learning from Death report from Nottingham into these themes. And some of you who've read this will recognise these. So they said that there needed to be continued efforts to increase rapid access to senior specialist opinion in the emergency department and other admissions areas. There needed to be more senior involvement in some interventional procedures. There was a problem in the written summary of communications with family, and that could be strengthened. There needs to be improved recognition of and access timeliness to treatment procedures. That there needed to be more effective monitoring, investigations and subsequent intervention, and there needed to be strengthening of handover both internally and externally, and that there needed to be earlier recognition of nutritional status and processes for monitoring and recording this. And what I find frustrating, and I'm sure I'm not alone, is that none of these things are new. We know about all these things as being problems: communication, recognition of deteriorating patients, end of life planning, consent, documentation. They've all been mentioned before in all the reviews and investigations that have gone on over the last 20 years. Mid-Staffs, Morecambe Bay, Southern Health, more recently at Shrewsbury and Telford, East Kent, and even in the National Confidential Inquiry into Patient Outcomes and Deaths. And there was a report published here which collated all the information. It was published more than 10 years ago, which showed that these were the main things that come up time and time again: consultant review, supervision of trainee doctors, multidisciplinary review, documentation, consent, monitoring and early warning scores. And it's the same thing over and over again, which questions really, are we learning? So back to the learning from death reports. The most common action themes found nationally, so what people did after they had this learning to make a difference. They reviewed and improved process, which included governance, risk, pathway, strategy. They highlighted guidelines or protocols, policy, use of guidelines or policies, or protocol treatment, bundle and toolkits. They implemented programs of work or education, which could include simulation. They did quality improvement work or similar. They did work to improve communication, collaboration, sharing of learning. And particularly in 2018-19, more and more trusts discussed that they wanted to improve documentation or coding. And as you can see, Nottingham University Hospitals, it's very similar to everywhere else nationally, cited lots of these actions as a result of their learning. And similar in the learning, that the actions haven't really changed over time. The only one that's particularly changed, as I mentioned, was real work to try and improve documentation. And in Nottingham specifically, between 2017 and 18, in the learning from death reports, they mentioned these actions. They were going to establish a handover task and finish group to review handover processes. They were going to learn from reviews and investigations to inform key safety improvement priorities. That care pathways were reviewed and standard operating procedures were updated. They were appointing a lead medical examiner to head up the medical examiner team. That the National Bereavement Care Pathway was set up in order to learn and improve the level of bereavement care associated with pregnancy-related loss, and that the mortality surveillance group had been using patient stories following a death to share learning across the divisions. And then the next and last part of the learning from deaths statutory requirements was an assessment of impact, and many trusts struggled with this. And in fact, in 2017-18, Nottingham University Hospitals didn't describe assessment of impact of actions, and they definitely weren't alone in that. Only 47% of trusts were able to discuss either a plan or that they had assessed impact. And in 2018-19, this increased to 57%, and Nottingham University Hospitals did describe assessment of impact through the use of audit. And the reasons that many trusts gave for not assessing impact, and some of them quite rightly, many of the actions are difficult to objectively assess in terms of their impact, as they may relate to rare occurrences, which are difficult to meaningfully audit. And it's not possible to comment on the effect of these actions in the time period under consideration. But it's also notable that many trusts seem to misunderstand what it meant to assess impact, and they just reiterated the purpose of the Learning from Death programme instead. From the non-statutory reporting, this was very poor, which you may expect, but was disappointing because involvement of families and carers was a really large part of the Learning from Deaths programme, and there was a very big patient-public involvement in setting it up. And they published this leaflet, which you can find online, which is information for families following a bereavement. So only 17% of trusts in 2017-18 involved families or carers either in the investigation or the review of the death. And this increased in 2018-19 to 37% of trusts. And I guess it is important to mention they may have been doing this, but they didn't mention it in their report. And with regards to sharing learning, so in 2017-18, 48% of trusts shared or had a plan to share the learning more widely within their own organisation. And Nottingham University hospitals describe sharing learning using patient stories across the divisions through the mortality surveillance group. And then in 2018-19, 41% of trusts, so I'm not sure why, but it went down, shared or planned to share learning. And in the quality accounts, Nottingham University hospitals described sharing learning via the patient safety newsletter. They said that there was a Learning from Deaths biannual workshop and that there was a quarterly Learning from Deaths newsletter, which I'm sure many of you have read. And then it's important to note as well that the sharing of learning outside of the trust was very poor, but this is again not to say it wasn't being done, but it just wasn't reported. So only 8% of trusts shared the learning more widely in 2017-18, and this was increased to 13% in 2018-19. And Nottingham University hospitals did describe making links within the integrated care system to improve cross-boundary learning in their 2018-19 report. So what does it all mean? So I do believe that the Learning from Deaths programme has improved the way that trusts identify, report, investigate, and to some extent learn from deaths, but that more needs to be done to enhance and strengthen the programme impact, and that national programmes should be developed to tackle the most common problems, to really find actions that create impact to prevent preventable deaths, and that further work is needed to understand which actions result in the biggest impact. And as a result of this, we made these recommendations in our paper. To improve reporting quality, there should be a more structured Learning from Deaths template. The NHSE and I should give specific guidance about how to assess impact of action, since that was a really big problem for trusts, and that there should be, they should reinstate Learning from Deaths regulatory reporting oversight in addition to CQC inspections. And to improve actual learning and action from death, there should be further investigation into how trusts involve bereaved families and carers. There should be more investment in leadership and support for staff to enable a just safety culture, and that there should be further utilisation of the medical examiner system in this programme. Thank you very much for listening.